Hello, I'm John Boyages. Welcome to this program on Dementia Behaviour, a management challenge, coming to you on the Rural Health Channel. In Australia, there are now nearly 300,000 people living with dementia, with a staggering 1,600 new cases diagnosed each week. Dementia is accompanied by significant psychological and behavioural changes. These present a real management challenge to health professionals, families and of course their carers. This program will give you a practical guide to meet this challenge. The program is a live, simultaneous online webcast and television broadcast over the Rural Health Channel. This is a dedicated, free-to-air health television channel on the vast platform. We welcome viewers from across Australia in places such as Ingham, Sale, Mount Gambier, Coonamble, Rockhampton, Charleville, Alice Springs and Casuarina in the Northern Territory. Professionally accredited programs from the Rural Health Education Foundation are broadcast on Channel 600 along with health education and information programs from other organisations. More information about the channel can be found on the Foundation's website www.rhef.com.au/RHC. As with all of our live programs, you can of course ask questions of the panel by email, phone or fax. The details are on the screen now. Send your emails to questions@rhef.com.au or call us on 1800 817 268. You can also fax your questions to 1800 633 410. If you are watching the webcast on your computers, type your question into the live talk box at the bottom of the screen and simply click Submit. We will be taking questions throughout the panel discussion, so please send them in as they arise. As usual, there are several useful resources available on the Rural Health Education Foundation's website www.rhef.com.au. And to kick off the program, we'd like to start with our first poll question. We want to ask you where you are. Tick one answer: metropolitan, regional, rural or remote. Now let's meet our expert panel. Angela Crumby. Ange, welcome.
Thanks, John.
Angela is the Operations Manager of the Collaborative Health Education and Research Centre at Bendigo Health in Victoria. Ange, you must work with dementia to be here, so what's your interaction with patients with dementia?
I most certainly do. A lot of my experience has been clinical work with people with dementia in the psychogeriatric units in Victoria, and I'm currently undertaking my PhD with GPs in detection and management of dementia in rural general practice.
So you sound like you work 24 hours a day.
Yes, so now I tend to work with carers, both informal and formal, on actually developing the resources, guidelines, protocols to help manage behavioural symptoms in dementia.
Fantastic, and we'll be talking a lot about that information later in the program. Karen Grant, our next panellist, is the Practice Nurse Coordinator at Health First Network. She's involved primarily with the GP Plus Practice Nurse Initiative. Welcome, Karen.
Thank you, John.
And what's been your interaction with dementia patients?
Well, my interaction with dementia patients has been probably over around 15 years as a practice nurse. At the moment, my primary role is supporting nurses who are supporting people with chronic diseases such as dementia.
I can imagine that being a challenging job at times.
It can be a very rewarding job for me, a very challenging job for the nurses on the ground.
I can imagine. Excellent, thank you. Our next panellist is Professor Daniel O'Connor. He's a Professor of Psychiatry of Old Age and is Head of the Aged Mental Health Research Unit based at Monash University in Melbourne. Welcome, Daniel.
Hi, John.
And what sort of exposure do you have with dementia patients?
Well, I see people with severe dementia usually, a lot of people who are living in aged residential facilities who are referred to our service because they're very marked, very persistent psychological or behavioural symptoms. So I devote a lot of time to understanding what causes those symptoms, prescribing treatments, working with nurses, of course, who do the things that they do to help with problems, and spending a lot of time with families.
So it sounds like you're at the more advanced end of the
Very
dementia
much
scale.
so.
Well, thank you and welcome. Our next panellist is Damita Pond, who is a Professor of General Practice and Head of the Discipline of General Practice at the University of Newcastle. She has a long career of research on dementia in general practice. Welcome, Damita.
Thank you, John.
General practice, 5 days a week, 7 days a week?
Well, I'm a Professor of General Practice, but I am still in clinical practice a few sessions a week and have nursing home patients too. And I've been interested in dementia, as you said, for quite a long time, looking at what we can do as GPs, looking at GP education and perhaps the best way to interact with other members of the team across the primary healthcare team to help particularly with these behaviours, which are a problem in the community and in residential aged care as well.
You mentioned that team. It sounds like it's definitely a multidisciplinary team that looks after these patients and their carers.
Well, I think as GPs we interact with the practice nurses first and foremost, as Karen indicated, but then there are a lot of other people out there who can help us with behaviours, and I think Tim's one of them. So
welcome, and let's introduce our final team member, Tim. Tim Wallace is the General Manager of Research and Innovation at Alzheimer's Australia. Tim has a clinical social work background and is a General Manager of Research and Innovation at Alzheimer's Australia. And welcome, Tim, and what's been your interaction experience with dementia?
Thanks, John. My entire professional career has been in the field of dementia and primarily in the management of behaviours or behavioural and psychological symptoms. One of my roles that I have at the moment is actually managing what's called the Dementia Behaviour Management Advisory Services, which is a national 24/7 behaviour management service for carers to access when they're providing support and care to a person with dementia and having trouble understanding and managing some of those complex behaviours that can arise. Okay,
thank you very much and welcome. Look, let's start off by perhaps asking you, Daniel, what does dementia look like today?
Well, dementia is just a general name for a whole range of conditions that result in usually progressive changes in people's intellectual function, their ability to think and make decisions, to remember, to express themselves and care for themselves. The commonest conditions in Australia are Alzheimer's disease, vascular dementia, but there are a host of other conditions including frontotemporal dementia, Lewy body dementia, head trauma, alcohol-related dementia. The list goes on really, but Alzheimer's disease is certainly the most frequent cause. And everybody who has dementia is going to develop some change in their psychology and in their behaviour at some point during the course of a dementing illness. So the kind of psychological symptoms that we see very commonly are anxiety, irritability, unhappiness, moving right through to severe major depression with melancholia. Delusions and hallucinations, and the behaviours that we see are described sometimes in a pyramid from the most frequent behavioural changes like apathy, for example, or repeating questions because you've forgotten the answer. The commonest ones occur very frequently in a community setting, moving right through at the top of the pyramid, I suppose, to the most severe and distressing and disturbing symptoms like very severe and unprovoked aggression, for example. It's much less common, but very frightening when it happens. And in between, of course, that whole range of symptoms that I've described.
And I guess you mentioned a whole lot of other causes, but is it mainly because we've got the baby boomers coming through and people are living longer because we're treating their cancers and treating their heart disease?
We are. We just have more elderly people around, and dementia is an age-related condition. After the age of 60, it starts increasing exponentially with age. So by the time people reach the age of 90, about 40% will have met diagnostic criteria for some sort of dementia.
So 4 out of 10
yes.
people,
so
once
the
they get to 90.
I think the estimates now are about that we're really looking at a threefold increase in the numbers of people in Australia between now and 2050.
Right. That's staggering, isn't it?
It's very staggering.
It's scary. It's scary. Tim, my mathematics on the back of an envelope show that we're seeing probably 250 cases every single day are diagnosed. Is that an overestimate, an underestimate? Are people making this figure up?
Oh, well, I think there's probably a bit of that in there. I mean, I'm not sure that I'm not pulling it out of a hat. I mean, there's some science and logic behind it, but we don't really know how many people with dementia there are at any one point in time, because one thing we do know is that a lot of people who have memory concerns and ultimately may have dementia don't ever get a formal diagnosis. But certainly the current estimates are around 250,000 people at the moment, 300,000 thereabouts, and that's looking to increase as our population ages.
Okay, look, I might just take a moment, if you excuse me, to discover where our audience is from. So we've got 27% from metropolitan, 23% from regional, 46% from rural, and 4% from remote. So it's 50% from rural and remote. So welcome everybody from right across the country. We'll now just ask our second poll question, which is, which of these symptoms would cause you to consider a diagnosis of early dementia? And you may tick more than one of these: forgetfulness, disturbed sleep, depression, or trembling hands. So look, we've got a series of case studies here today, and I'd just like to go to our first case study, which is Joan. Now, Joan is 75, she's retired, lives in a rural town. Her husband Greg brings Joan to visit her GP for a 75-year-old health check with the practice nurse. He's concerned about Joan's memory. She seems to forget arrangements and appointments and some recent events. She sometimes seems confused and not quite sure what she's doing. Greg says that she no longer seems interested in her needlework, her craft and other hobbies that she's enjoyed for many, many years. She's having trouble doing the household tasks and actually dropping things. So Karen, let's assume she comes into your service. What would you do to start with?
Well, I would hope that I'd already have a relationship that is a therapeutic one that has been built up over time with this person. She's obviously come in for a 75-year-old health assessment, and so many of the things that myself or other practice nurses would be thinking about there is digging a little bit deeper as far as some of those symptoms or concerns that particularly Greg, her husband, has, and find out how long they've been going on for or when they were noticed particularly. Asking Joan the same, is she concerned about these things as well? And there's one other thing here that really interests me particularly, is that she doesn't seem interested any longer in things that have been a joy to her, and that's a bit of puts a bit of a question mark in my mind. And also she's having trouble doing some household tasks and dropping things. Now, when I first think about this, my mind goes not so much to dementia but to depression possibility. The reason I say that is, you know, losing interest in some of those things that are really important to you is a big issue, and there could be stresses involved. You know, there may have been recent stresses in her life that have caused her to get to that point, and also the fact that she's having trouble doing her day-to-day tasks in her household. And, you know, something that comes to my mind is that women tend to do very well at household things, and they don't tend to have to think too much about what they do because they do them over time and do them just as a rote thing. And so that she's losing the ability to do some of those things is a bit of a problem, I think. And
so you're saying women can do more than one thing at once?
Well, you know, women. It's well known, John, that women have the propensity to do more than two things or more than one thing at a time. And that's not to say that men haven't got that same ability, but it's well known that women do that very well. And the fact that she's having difficulty with this is a bit of a concern for me. So as a practice nurse, I'd probably be digging a little bit deeper in the 75
So look,
assessment.
just for the uninitiated, very quickly, what does a 75-year-old check entail in terms of which areas are you checking?
Yeah. In the 75 health assessment, it covers all kinds of areas. Some of those are psychosocial areas and family support, social activity involvement, could be nutrition, activities of daily living, falls risk assessment. Nurses mostly do a mini mental state examination, which is your MMSE, and that could be with a clock drawing for someone who has a language issue.
It's quite comprehensive, isn't it?
Yeah.
So it sounds like a very good initiative. So, Dimity, the nurse says, look, a bit worried about this lady. What will go through in your mind now?
Right. Well,
is this early dementia or is it something else?
Well, I'd certainly have a look at that assessment that Karen's done, and listened, if possible, to what Karen's had to say, and then and have a look perhaps at the scores on the cognitive function test that she's done, whether that's the clock or the mini mental, or there's some others I believe on the website, the AMTS, which is quite a good brief screening instrument, and knowing Karen, she's already thought that maybe a depression scale is a good idea, being as you're a bit concerned about depression there, Karen. So that geriatric depression scale might be on there. It's certainly available on many doctors' software. So I'd have a look at all of those things. But John, I like to think of 4 Ds when I'm thinking of a case like this, who could be a case of dementia or depression.
Okay.
And the other 2 Ds, I think, are delirium. So I'd be wanting to know the timeline here. If this lady has only recently, in the last few weeks, dropped these activities and withdrawn socially, is there something going wrong with her physically? Has she got a urinary tract infection? She may be constipated. That often causes problems. Has she got a chest infection? Is she a bit hypoxic, a bit worsening of her COPD? I'd need to be examining her physically and thinking about those things, and perhaps looking at some bloods to rule out some disorders, electrolyte disturbance or something. And the last one is drugs. Have I given her a new medication, perhaps a medication with an anticholinergic side effect, such as the ones we use for urinary incontinence very often in general practice, or some other drug that's just tipped her into not functioning as well. So I think she needs a thorough assessment, John, before I'd rush into saying that she has dementia.
So would you, Daniel, did you want to say something
can
there?
I just chip in there?
Yeah.
I absolutely agree that depression has to be considered as a differential diagnosis in this lady.
Yeah.
She's lost interest in her former activities, and one reason for that could be that she's depressed. There's a trap though. A lot of people with moderate or severe dementia who come to see me are on antidepressants and have been on them for a number of years, and the reason they were putting on them is that their GP thought 2-3 years ago, is this person depressed? They're losing interest, they're not managing well, they're not eating properly, they're losing weight. They might be depressed. That would be terrible if I missed that. Let's put them on an antidepressant. That might help. And having started on one, they then stay on them. And in fact, most of them, I suspect, were never significantly depressed.
Right.
Many of them had early dementia. I'm not saying this lady here has early, I'm not saying that, but many patients have early dementia. put on antidepressants to see if it will just buck them up a
Yes,
bit.
yes.
Doesn't, and they stay on them.
Right.
And I'd really like to encourage people, if they're going to start somebody on antidepressants, to really think carefully about whether they have a significant depressive illness with melancholic features and that that's persistent over time. That's just my little aside here.
That's a good point.
Sorry about that.
Look, I just want to cross-talk questions. A question coming from the email, Maman Shafiq. What investigations will Jane need? And would you consider imaging?
Right. Well, I think she needs bloods to exclude various reversible conditions.
Yep.
And the list is variable, but you'd need to look at thyroid tests, B12 and folate, electrolytes I mentioned. You might want to look at liver function tests to see if something's going on with her, a urinalysis at least, or an MSU. And there are others that you could consider in certain cases, such as, not with this lady, but perhaps with some other scenario, you'd be looking at HIV testing or syphilis testing and so on. I think we can't totally exclude a brain tumour or some sort of brain pathology. So I do think a plain CT, if that's available, and I understand, of course, with this audience that it's not always, it is a useful thing to do, just to exclude something that's not dementia but is giving a similar picture. I don't know what you think, Joan.
I think if I had dementia, I'd want somebody to have a look at what my brain looks like. Partly, I suppose, to exclude the remote possibility that somebody has a brain tumour. Most brain tumours present with specific neurological symptoms. But also if somebody has a very significant cerebrovascular loading and a lot of vascular pathology, that might dissuade me from starting them on a medication for Alzheimer's disease. It's probably less likely to be effective in somebody with very highly visible cerebrovascular disease.
Right. Can you, in a nutshell, say why? Is it related to the access of the drug?
Well, the cholinesterase inhibitors work best for Alzheimer's disease and for Lewy body dementia. They are not effective for cerebrovascular disease, so if that accounts for the preponderance of your dementia, it's probably not going to be fruitful for you to go on Aricept or one of the other cholinesterase inhibitors.
Okay, we might come back to those. What interventions we can use later. So let's just look at the poll question 2 result, which was which of these symptoms would you consider to be a diagnosis of early dementia? 55 of you said forgetfulness, 35 said disturbed sleep, 37 depression, 12 trembling hands. So what does all that mean?
Can I just butt in there?
Yes.
So I'd like to take Daniel up on this depression issue here. Because really, Daniel, it's true, isn't it, that it could be depression and dementia?
It could, absolutely.
And you might be able to ease someone's symptoms a bit with your antidepressant as a GP.
You could. But my request of you would be that you think very carefully about what kind of depression this person has. Right. We know that many people with dementia are unhappy, and you can, especially in the early stages when people have some understanding of what's happening to them. I think you and I could grasp immediately that if we thought that we had Alzheimer's disease, that we'd be unhappy about that, we'd be unhappy about people asking us to do things that we are struggling to cope with. It's just tiring and dispiriting to be in that situation. But that doesn't mean to say that you're going to benefit from an antidepressant medication. To benefit from an antidepressant medication, you have to have a persistently low mood, you have to have lost enjoyment in the things that you normally do, and Joan has that, I know. You have to have some feelings of despair and hopelessness, loss of appetite, weight loss, sleep disturbance. The more of those symptoms you have, the more severe they are and the more persistent they are, the likely you are to benefit from antidepressant medication. It's my contention, actually, that 90% of antidepressants are a complete waste of time and money. But some people with dementia do have significant depression overlaid on their dementia, and some people with depression might look as if they have dementia when they don't. So you're absolutely right.
Yes.
Everybody's right to think about it and identify depression and to treat it when it's there. But if somebody with dementia is failing and struggling and unhappy, that in itself wouldn't, in my view, be the right trigger to make you prescribe an antidepressant.
So there might be other things we can do. And I know that people with memory problems may benefit from exercise, for example. And that often benefits people with depression.
Absolutely.
So getting that person out, maybe getting them socialising a bit, also good for memory problems or cognitive impairment, and also good for depression. Maybe making sure they have some of the things they enjoy in life, the music and so on, that they enjoy, giving them pleasant events.
Yes.
So all those non-pharmacological things that we use for depression.
Could be more helpful
Yes.
than an antidepressant medication.
And they might also be good for the cognitive impairment, such as it is.
We
That's right.
might just get have a quick question here for the panel from Joan Catlin, consultant pharmacist, asks, coming from the pharmacist's point of view, would it be wise to check what medications she's already taking? You sort of implied that when you...
Yes.
but
I completely agree, and I think a pharmacy medication review is one of the home medications review is another great idea. I think the evidence is that they work a bit better if the GP's involved, perhaps verbally with the pharmacist rather than just a report, you know, and the pharmacist filled in on the whole clinical picture and what the questions are. So it's a real team effort. But I think the pharmacist is a very significant team member that can help us with working out what's going on with dementia. And it may be that someone's been on a medication, say a benzodiazepine for sleep, for the last 20 or 30 years. And we still have a lot of people out there who do. And, you know, their brain at this age can't handle it the way they could when they were 45.
so it seems to me this stuff's not easy, right? It takes a long time to assess the patient. You need to do tests. You need to check out their drugs, look at their whole family situation. We've got a question from a GP saying, "Don't we need to send the patient to a neurologist?" Is that surely just do a CAT scan if you're worried? And then send it to a neurologist, or?
Well, if you think that somebody has Alzheimer's disease and you think they might benefit from medications for Alzheimer's disease, then they have to be seen by a specialist.
Okay.
Not necessarily in person. I think they can be seen. Is that right, Damita? By you could have a consultation in writing or by telephone between the GP and the specialist.
Yes. I had a look at the PBS guidelines and it says in collaboration with. By or in collaboration with. So.
And certainly the specialists involved in that process are geriatricians, old age psychiatrists and neurologists. I think it would depend on who was available, who had an interest in dementia, who the GP was familiar with and trusted.
Okay. So Dimity, sorry to keep picking on you, but what's this 14 essentials for good dementia care? You know.
Well, that's actually a fantastic tool that was developed by Henry Brodati, and it's up on the website that everyone's hooked into. So it looks like that. I know you can't read the whole thing, and I'm not going to read it out to you either. But I'd say the first half of it covers this assessment that we've just been talking about in more detail, so people can check on that. And then the second half talks about management. And I believe, you know, that much of the rest of the program what we're talking about is sort of summarised in that second half. So it's a great, easy to read summary for anybody out there, GPs or nurses or whoever wants to look at it, on what you ought to be doing when you're thinking about someone with possible dementia.
Okay, well, thank you for that. And any quick points before we go to our second case about that first, about Joan? If not, we'll just go to our second case, and which looks at Dorothy. She's 82. She's been admitted to a rural district hospital with bronchitis and pulmonary edema. She has not been eating or sleeping well. She's been prescribed temazepam and furosemide. She's wandering at night, undressed and complaining of bad dreams. She appears agitated and confused. She has been living with her daughter, who reports that she has been increasingly depressed, forgetful, irritable, particularly at night. On admission, the nursing unit manager calls for an ACAT assessment. Tim, you've been pretty quiet. What do you think? Is this dementia or delirium or both? What do we do from here?
I think it's a great question, and there's no simple answer to these questions, because it comes down to, as Damita was saying before, assessment. If you don't do thorough assessment, then you're sort of just taking a stab in the dark, and you might get lucky or you may not. I think certainly there's some concerns that I would see from that presentation, that the medication she's on are going to increase the likelihood of getting, comorbidities that, like delirium, similar sort of things that you'd expect we get all the time that would cause delirium. But you've got a dementia presentation too, and if you've got an increasing sort of presentation over time, that tells you that something's sort of certainly changing. And so I think the critical part is to really do a thorough assessment from the first step, the delirium screening, and then once you've done that, you can then start to look at eliminating certain causes and trying to do interventions that actually may make a difference.
Okay.
Because I suppose the point is, isn't it, that dementia is the big risk factor for delirium in very old people. The old people who get delirious are often people with dementia. They have failing brains, and it takes very little to push them over into frank
so you're saying it's
delirium.
catch-22, it's all
It
connected.
would often be a combination of the two, and your history, I suppose, is going to tease that out, isn't it? That you have somebody with increasing cognitive impairment over months or years, and then in the last 3 days, as this lady's tipped into pulmonary edema, she's become extremely confused, agitated, distressed. She might be hallucinating as well.
And Daniel, I like that as a cue for the GP, the poor old GP who only sees people for 10 or 15 minutes at a time, repeat medications, don't know what's going on. If that person has been in hospital and had an episode of delirium, I think that's a great cue for us as GPs to start hunting around thinking, oh, maybe we should get our practice nurses to do one of these assessments. Maybe this person's got dementia,
So
an underlying
I'm not
dementia.
saying they all do,
No.
but the more dementia somebody has, the higher their risk of delirium.
Yes.
That's a very
And
good
delirium
point.
doesn't always get better completely. People will often lose function as a result of delirium.
That's a good point, because we sort of put them here and here, but you're saying that there's overlap and interaction. Ange, any comments so far on this case?
Look, it is a really tough one. Dementia and delirium, you really need to rule them out. As Damita said before, there's actually the 4 Ds, but probably the delirium and dementia are the two hardest ones to distinguish between. And certainly, the acute onset, I think, and the probably the consciousness level would be your two main indicators, wouldn't it? Dementia is never an acute onset. Delirium is acute. So that's sort of your first trigger, isn't it? So, yeah, a good history and some good screening would not go astray.
Okay, well, thank you. Look, what's this ABC model of care?
Well, I'm glad you asked. The ABC model of care is a really simple way of characterising behaviours. It really is. It sort of gives people a bit of a framework. Sometimes we find it a bit of a challenge to work out a sort of systematic approach and way to go about looking at behaviour management. So the ABC really looks at the activating event. So even though we don't always know what the activating event was, there always is one. No one behaves in a certain way for no reason. So the first thing again is taking history and really looking at why, what happened immediately before this, this behaviour to precipitate the event. Then of course you look at the behaviour, what happened as a result of if it was aggression, was it verbal, was it physical, was a weapon used? And I don't mean knife or gun, I mean the most potent weapon I've come across is a stainless steel urinal and a walking stick. So you've got to sort of look at what the behaviours are, and then you're going to be able to manage them a bit better. So, and is the behaviour actually causing harm to someone? So because of course your strategies will be a lot different. And then your C is your consequences of the behaviour. So what happened? Is it the only time that this person gets attention? So are we negatively reinforcing this not so positive behaviour? And of course, if behaviours aren't well managed, they will escalate. So we really need to look at the consequences. And the other C that I put in here too is communication, because the way you communicate at the time that someone's displaying the behaviour will certainly impact on the resulting consequence. And of course, we've added a D, and it's decide and debrief. So when the behaviour episode, I suppose, is over, we really need to work with the team again. It's all about teamwork and looking at what happened and what we can do to prevent this from happening again in the future. It's really important.
So you do a stock take of that patient's bloods and medicines again, and see if you can find that activating factor.
Most certainly. The activating event also, I guess the A I always think of too is the assessment. You need to assess why the behaviour actually occurred. So use all your assessment skills, your assessment tools to find out exactly what was going on around that person at the time. And knowing a person's history is really important there, because you know, they could just be responding to something from the past. So really looking at the reasons why that behaviour occurred.
One of the problems I have with the A as an ABCD model is, I think, you know, it's a simple model, but it's sometimes too simple, because we know that behaviours are not necessarily simple in their presentation. I mean, the behaviour that's happening makes perfect sense for that person at that time, and it's in the context of their entire life, and their entire life is an incredibly complex thing, along with the disease and all the other factors that come into it. And one of the models I'm a big fan of is the progressively lowered stress threshold model, because that talks about essentially that there's a number of cumulative stressors that person has in their life, and the thing that immediately activates or precedes the behaviour may not be the actual thing that's triggered it. It may be all the other stressors that have a much bigger factor in that presentation. And if you focus on the A, you miss those. And this is probably as good a time as any, but we have this resource book that we've developed as a service, which is available from our website on www.dmass.org.au. And that talks about the number of the different models that can use to be conceptualising behaviours, because we know that there's no simple explanation for behaviours. Sometimes there is, sometimes there's a complex explanation, sometimes we have no idea why the behaviours occur, but we find some things that actually can make a difference.
Look, I agree entirely, and that's why this framework isn't meant to be a work out what the behaviour is. It's a framework to manage the behaviour. It's assess it, work out what it was, work out the consequences, then decide and debrief and work out your management plan from there. Because as you say, there's often a few causes for the behaviours as well, so you can't always just pinpoint one simple behaviour or one sort of activating event. It could be a lifetime history, it could be, you know, something that happened yesterday, it could be someone walked past and they reminded them of someone, you know, things like
look,
that.
Thanks for that. We are getting quite a lot of questions about some practical tips of what people can do. Now, we've got sort of two customers in a sense. We've got the poor old patient, and you've got these carers who in some ways, I guess, have to live a long time. Perhaps someone has to leave their work and look after their family at home, difficult decisions about placements and all sorts of things. There's a question here from Raymond Haddon, psychologist, who says, is there a wide variety of exercise and activity which may be more beneficial than just simply walking? So let's think about, let's talk a little bit about what sort of simple advice are you giving, perhaps more in the mild to moderate range, and then perhaps in our third case we'll go into the more advanced cases as well. Who wants to start with
Certainly.
that one?
Well, one of the better exercise, or one of the good exercises, I believe, is dancing.
Okay.
You know, it's physically enjoyable. It's it's physical exercise, but it's also quite often the music is soothing. The actual, like even if you're dancing with a partner, the touch is reassuring. There's a lot of positives to actually dancing and making it a physical exercise, but an enjoyable activity at the same time. That's my favourite.
Can I just interrupt, John? And I mean, that sounds fine. I have no problem with that at all. The research evidence is, if we're looking at people with dementia who have some anxiety, irritability or agitated behaviour, for example, the treatments that work best are treatments that are really geared to that person and their background, their personality and their interests. So all I would add to what you're suggesting is that if somebody has enjoyed dancing, they're likely to do so now and benefit from it. There are some people like me who actually don't like it.
No!
and I think if you were to propose that to me, I might actually get more agitated.
What about the Wii Fit and the Wii Sports? That's being introduced into a lot of aged care.
So what you're saying is you need to know that individual.
I think so, which I think was what you were saying.
What you're saying. Yeah,
really the treatments that work best are really more to do with the person than with the modality of
move on.
Psychosocial treatments that you're offering.
Let's move on. It sounds like we need an individualised care plan, and we've got to constantly review that plan. That's what I'm hearing you say, and it's sort of like a cycle. So, look, let's go to our next...
Can I just, before we leave this case, though, I mean, you couldn't not move on without saying that the thing to do first for her is to treat her bronchitis and pulmonary edema. I mean, we're hypothesising that she has dementia and delirium, and she's going to die unless you do that, and everything else sort of follows from that, I guess.
Thank you. So, look, our next poll question, what do you consider are the 3 most challenging dementia behaviours to manage? Physical aggression, wandering or intrusiveness, sexually inappropriate behaviour, resistance to personal care, problems associated with eating, sleeping disturbances. So please have a look at that. So let's go on to our third case study. This is a case of more at the pointy end of that triangle that Daniel showed earlier. Otto is an 82-year-old ex-farmer. He ran his own farm after arriving in Australia as a 20-year-old. He was a farmer in Hungary. He is a big man and still relatively strong. His children placed him in a residential aged care facility after his behaviour on the farm became just too difficult. He has severe cognitive impairment and often reverts to speaking in a mixture of English and Hungarian. He sometimes seems depressed and non-communicative, but is often agitated, anxious and incoherent. He's always on the move, will often eat anything lying around and always wants to get down to the paddock or just check on the cows. He recently hit 2 other patients after becoming frustrated with them. The aged care facility contacts DBMAS for advice. Tim, do you get a lot of these, or these questions, or these sorts of patients?
It's a very sort of typical presentation. Really? The sorts of things we get referred. I think we did some stats, and it was around 70% of our referrals are where there's physical aggression or physical violence, and it's not always physical. Sometimes it's verbal, and sometimes it's just the gesturing, the waving of arms. So yeah, it's very common, and I think one of the reasons it's common is because of staff stress. That of all the behaviours, it's one of the most confronting. It's not the most frequent, but it's certainly very confronting because staff don't know how to deal with it. I think when you're looking at something like this, though, there's a few things that I'm always very mindful of when a person gets referred to us with aggressive behaviour or physical aggression. And there's other presentations too that you're talking about with this person with the eating of all sorts of things. I'm not sure what those things are. But the most important thing for me is really good documentation around what's actually occurred. With only 2 incidents of aggression, I can go in and see the person in the facility and they may not be aggressive, and this person's been labelled as aggressive, and I go, well, I'm not seeing an aggressive person, I'm seeing a Hungarian man who's doing his own thing and making sense of the world. So really good documentation around what actually happened, the antecedents, behaviours, consequence kind of model that Andrew was talking about before, is a really good starting point to actually start to inform us about what does this behaviour mean for Otto. Because whatever he was doing, it obviously made sense to him at the time, and we need to start to understand what made sense to him at that time. He's obviously very, very confused and doesn't even necessarily know where he is or why he's there. So
what can you offer the facilities? Of more explanation, understand the problem, and then what?
Well, I think if we just said, if this was a typical sort of situation, then I'd say that Otto's physical aggression may have been in relation to care being provided, resistance to care, that staff were trying to intervene or do something for him or to him, and he had no comprehension of what was going on. And so he's seen that as quite affrontive and tried to defend himself. A very natural sort of thing for a person to do when they feel assaulted is to defend themselves. And I think the best thing we can do in that is to really understand the situation and educate staff so that they can adapt their approach to Otto. And they have the best chance because Otto can't really adapt his approach to care staff. I mean, dementia impairs his cognition, impairs his ability to reason and understand, whereas staff still have that ability. So I think we use the resources we have, which is capable staff, and manage the resources we don't, which is Otto's cognitive impairment.
So what do you make of this email from Michelle Zimmerman, who says, "Hi everybody, could you make a comment on the Late Line program aired on the 16th of August, how Australia has one of the worst records for using chemical restraints for dementia clients, please?" Did Late Line blow it up, or did anybody watch that?
I did.
Did you?
It was a good program,
right.
I have to say. I don't know whether Australia is worse than other countries, but we do know that about a third of people living in high-level care residential facilities are taking some kind of psychotropic medication. It could be a benzodiazepine, an antidepressant, an antipsychotic, or more than one of those in combination. And we know from studies done in Australia and the UK that with respect to antipsychotics that might be used to help people with very agitated behaviour, that they can often be withdrawn without any adverse consequences. So they might have been helpful at some point, but they're not helpful now, and that's proven, I guess, by the fact that they can be stopped. And 90% of people can manage quite well without them. 10% of people, though, do become more distressed and agitated and might need to go back on them. But 90% of people can come off
Is that the real world, or are you seeing far more than 10%? Just sounds a bit low.
Well, I mean, ideally, with someone like Otto, I mean, it could be that as a GP you get asked to provide medication for this man, some sort of sedative something, and really we haven't gone through all those stages you talked about, Tim, or Ange, of looking at the antecedents, behaviour and consequences, because that does take time. And I do think that sometimes, in the real world, we're very busy as GPs. Residential aged care staff are incredibly busy themselves. Often there's a high turnover rate, and it sometimes seems easier just to pull out that prescription pad. Now, I'm not saying that we even think that that's what we ought to be doing, but sometimes in the real world it seems to be the only option. And this is where DBMAS comes in. I think the more we ask for them to help us, the more they'll be able to cut into that cycle and start trying to make sense of Otto's world and look at behavioural interventions that can be useful instead of doing that. And it may come to the time, as Daniel said, when in fact that medication's needed because nothing else will work. And I think there is a place for those things. And that's why risperidone and some of those drugs are actually licensed for us to prescribe in the case of behavioural disturbance associated with dementia.
Could I just add a comment there? I think the idea of it really understanding why this behaviour is happening is just so critical. I mean, it could be that this poor man has less and less ability to comprehend staff who are talking to him in English. That's frustrating, it's difficult for him. He wants to be outside, being confined in this place might be very hard for him. So all of that would make sense to me. But in addition, complicating that, he might also be extremely anxious, and we might be able to help him with that. He might have psychotic symptoms. It happens. A proportion of people with dementia do come to believe that staff are poisoning them, for example. I would want to exclude that. I'm not saying that that's his problem, but as a psychiatrist, I would just want to check that that's not the case, because if it was, he would benefit from an antipsychotic medication. I also want to check that he's not severely and persistently depressed. He might be. He doesn't know why he's there. He's frustrated. He can't communicate with people. He must be very isolated. he may well be very depressed, and part of being depressed is to feel anxious and irritable. And if he's feeling really sad, really miserable, really irritable, and somebody speaks to him the wrong way or intrudes into his space, then his reaction to that might be to hit
short-term antidepressant, and which one?
If I thought that he had the kind of depression that I described earlier, a really good-going major depression with melancholic symptoms, disturbances of eating, sleep, appetite, and so on. I don't mind what antidepressant you use. If he was having difficulty sleeping, an antidepressant that helps with that, like mirtazapine, could be very helpful.
I think this is my big concern, though, that the approach that we often take is I need a quick fix, and nurses who go through their training and end up working in residential care and aged care, they've grown up in an environment which is often not predominantly but largely heavily influenced by the medical world, the medical sphere, and it looks at a medical way of treating these things. And then if you give someone a hammer, that every problem will become a nail. And I think that when we look at things like medications, what we often see as a service is that most of the clients who get referred with behavioural symptoms, particularly when they've been in residential or acute care, they have a number of medications that have been put on place and been told they don't touch the side, so they increase the dose. And then our service gets involved, and we look to work with the pharmacists, to work with the GPs, work with the specialists to titrate those medications to an appropriate level, along with other strategies, psychosocial strategies. But then we often have repeat referrals where the person has had a locum come in and prescribe another medication to fix a behaviour that happened once, a week ago, with more medication. So I think there's a real fixation, I think, in aged care, that we look at medications as a quick fix because they're simple to prescribe and simple to administer, but not necessarily effective.
And often hard to get off them because, I mean, these poor patients often see geriatricians and they tell them to bring the brown paper bag in with all the medications, and partly trying to figure out all those medicines, I suppose, and which ones they really need now. Do they still need their blood pressure tablets and so on? So I guess you've been all saying that.
And I know Tim is like that about us doctors, and that's probably reasonable, but how long would it take DBMAS to... I mean, if this person's sort of hitting out at people and it's a fairly urgent situation, would a facility be able to rely on DBMAS coming in 24 hours, or might it be longer in some parts of the country? Or
absolutely. I mean, there's no sort of... I mean, we're not an emergency service, we're an advisory service. And we work with the facilities, we work with the GPs, we work with all the services that are involved to try and provide optimum care. But I think the problem I have is that a behaviour that occurs once is suddenly an emergency, even though the behaviour's happened and it may not happen again for some period of time.
So we've got the a graphic there with a 1-800 number. So it sounds to me like it's a vital service, but as the incidence goes up, everybody on this panel is going to be stretched, and it's going to be tricky. Look, I might just go to the poll question 3. Let's find out what are the 3 most challenging dementia behaviours to you. Physical aggression, number 1. Wandering or intrusiveness, number 2. Resistance to personal care, number 3. I guess I know where I work at Macquarie University, they've got an art museum, and they do talk highly of bringing dementia patients in for art therapy. Is that something, like someone as severe as Otto, get him out of his confines? Is that sort of what you're saying? Get him to the outdoors is what he's used to growing up from the age of 20? Or is that how you tailor some sort of interaction? Perhaps get him less bored and less aggressive? Or was it being too simplistic?
You'd tailor the strategies according to what Otto really likes. As we said before, it's all really person dependent. Otto's a farmer, so he obviously wants to go out and get the cows and all. He's obviously likes the outside. So is there a safe area for him to wander? Is there a fiddle board? Are there things like that you could actually get him to fill with pictures of cows, discussions with the...
Listening to cows lowing.
Yes.
A cow section in a facility with cow
and that's
pictures
where
on the wall.
volunteers
Anything.
and families, you can...
be creative.
You often see Labradors and things coming into facilities and pet therapy. Or
we had a miniature horse.
A miniature horse,
well.
okay.
Yes.
So...
and art therapy is really good.
It is good?
And I've had a PhD student doing art therapy with people with dementia. and she was a psychologist and an art therapist. And really, you know, over sort of 8 weekly sessions, she's got records of their verbalising improving from sort of 5 words in the first session to, you know, a whole story that they would tell by session 8. Just from that amount of time spent
I would
with
say,
her.
Damita, though, that the evidence is now very good that that's exactly the sort of response that you can get from people with a lot of dementia if you provide time and real attention to them.
Yes.
Whether you offer them art therapy or Montessori activities or horses, what might matter more is how well this is attuned to this person and their background and that interest.
Well,
because there might be somebody who just throws the art board in your face. And
what I've said to her is there aren't enough art therapists out there, but Daniel, I've heard that you're doing something with the relatives providing some of this.
That's right, using relatives who are familiar.
Not art therapy, but something else.
No, I mean, I suppose what the family brings is knowledge of this person, what they've enjoyed doing, their culture, their background, their likes and dislikes.
Right.
That's what they can bring.
And if they just spend time...
And spending time with this person, really paying attention, which sounds so easy, and yet it probably happens very uncommonly, I think, especially for people in residential care. Having anybody really sit with you for half an hour or an hour, paying attention to you and responding to your cues, responding to the fact that you're not liking something and want to change direction. That happens so rarely,
wonderful.
Actually.
It sounds very much like diversion therapy and validation.
Yes, that's right.
As to one. And I think maybe that's where they've gone wrong with Otto too, is, you know, when he wants to go and check on the cows and down the paddock, they're probably saying, no, there's no cows and you can't go down the paddock. You know, you've got to validate those, the
Look,
feelings.
there's a question from the audience. You know, he's been in a lot of farm work. Could he be in pain? Can he verbalise that?
I meant to mention right at the beginning that, as well as thinking about depression and psychosis, always think about pain and think about trying an analgesic to see if that would help. Can I just, we've been talking about sort of psychosocial treatments and how, you know, a lot of people on psychotropic medications can come off them without being adversely affected in any way. They benefit from it, actually. I think there are people who do need to be on medication, people who are very severely depressed, people with psychotic symptoms, and people who are just so agitated and so unpredictably aggressive that staff and co-residents are at real risk, because if staff are going to get badly hurt, they're off the floor, they're going to be replaced by agency staff or by completely untrained people. They're going to come back being very anxious and very apprehensive about dealing with that particular resident or residents like them. They're going to become avoidant of people who look like they could be threatening.
It's a no-win situation for everybody.
It's a no-win situation, and
it?
I think that we know from randomised controlled trials that antipsychotic medications can reduce agitation and aggression. Not in everybody, and they have side effects, but if you're really thinking intelligently about what you're doing and you're not responding to the, oh, somebody got hit and we have to just move in and do something now. I'm not suggesting that or advocating that for 1 minute, but there are instances where medications have a role, and I think to imply that medications are only used for staff's convenience to keep people quiet is really undermining of good staff who are entitled to be safe, actually, and co-residents are entitled to be safe as well.
Look, we've got a few questions here. I'll try. Some of them we've already dealt with, but if there was depression and dementia, how then would you differentiate a component of apathy, which I believe is a common dementia effect? Does that make sense to you?
That's a very good question. I mean, people with dementia often have apathy. That can be a very early symptom. And people with depression have apathy too. They've lost interest, they enjoy things less, they will sit doing nothing, just feeling very distressed and upset inside. So working out which of the two is which can be complex. What is the key to the sort of depression that I'm talking about is looking at the person. Do they look unhappy? Do they look sad? Do they look miserable? almost all the time. If you say to them, how do you feel? A person who will still be very confused, might be quite dysphasic, might still be able to say, I feel bad, I feel rotten in some way. They may not be able to articulate it or describe it in great detail, but they'll be able to communicate to you that they feel bad. The nursing staff or the family carers will be able to tell you about changes in sleep and appetite and so on. People might be tearful, they might talk about wanting to die, and the more of those signs that you see, the more you think this could be depression. It may be overlaid on dementia, and that's the sort of depression that's likely to benefit from antidepressant medication.
Thank you.
Is it true that on some of the tests, like the cognitive function tests, someone with depression is much more likely to say, I don't know, because they can't be bothered answering the question, and someone with dementia will try and make something up? So is that a bit of a giveaway?
No, I think that would, if somebody says, look, I just can't do it, I don't know. Of course, they may not know the answer. They just may not know.
But if they don't know
if they
every
give
question,
up, if they give up, people who are very depressed just give up easily.
Another quick question, I hope. I often find GPs, this is from Roseanne Brooks, an occupational therapist, and health staff don't raise with the person with dementia and their carer or spouse the issue of grief reactions and behaviours to loss of independence function and impact on their vision, their future plans for what they thought old age would look like. That's a tricky question.
Can I just chip in here? One for the practice nurses, we do. We would talk to the person about that type of thing. I was thinking also about advanced care directives and that type of thing being introduced at practice nurse level. We're trained to actually, most practice nurses will be trained in respecting patient choices. So, you know, these are some of the issues that might come up in that conversation as we introduce that to them. But yeah, it is a grief, and I think, you know, quite often we're a little bit removed from that. But in delving in the 75 plus assessment that we tend to do often, we can actually pick up on those.
You empathise with the carer.
And they share things with us quite often that they may not share with the GP, and it could be just because of the time factor. You know, we have a lot more time to be able to spend with them.
How hard must it be? You know, daughter's had this wonderful close relationship with her mother all her life, and they chat on the phone and have coffee together, and suddenly that communication stops and they're still alive. That must be so grievous. Yeah, because you know, with a wound, a leg wound or a physical wound, you can see that on the outside, you can somehow fix it. But something that's hidden and it's on the inside that's not visible to family members or to carers or to just people in general that aren't going through what the person is going through. It's just, it puts it in a whole different realm, and it is a grief, it's a loss. Look, there have just been so many questions, and it's such a broad area that the panel has had to cover tonight that I think, in the interest of time, we'll go to the resources and make sure people understand those, and then I'll come back to you and ask you to think about a take-home message for our audience. So, look, resources for health professionals and communities are available. And these will be they're useful websites on the screen now, and they'll be on the RHEF website. But look, let's get some take-home messages, starting with you, Daniel. Sorry. It's getting late. Tim.
Sure. I mean, I guess I'd say that dementia is not a normal part of ageing. Behaviours are very common within dementia, but there are things that can be done. And so, you know, there's a lot that can be done. Give us a call if you don't know what to do. 1800 699 799.
Thank you. Just repeat that again.
1800 699 799.
Excellent. Okay. Damita.
I'd like to say that we need to be aware of dementia, early dementia, and not be afraid to look for it, but be aware that we can't just label every single person with a memory problem as having dementia. That's the first thing. And the second thing is, when we're getting to issues around these behaviours, there are a lot of people that we can call on in primary care, and I think we need to become aware of who we can call on, perhaps in our local area particularly, and call on them when we need them.
Thank you. Daniel?
I suppose I'm an advocate for really understanding the person with dementia and choosing psychosocial approaches to challenging behaviours that are attuned to that person's background, as I've said before. I'm also an advocate for the really intelligent and well thought out and well monitored prescription of psychiatric medications to help the kind of problems that they can genuinely help with.
Thank you. Okay.
Practice nurses are key in helping people in dementia, and they're key in flagging triggers, flagging issues and problems that are concerns with the GP. For GPs that don't have a practice nurse, get yourself one because they're wonderful, great coordinators of people's care, particularly in chronic disease management. We are very good at service and referral pathways, so we can get people involved with the care